Wonderful. Thank you very much, everybody, for joining in this series of COVID and Cancer Virtual Expert Board. I've lost count of how many we've done. So today is the nth meeting, and as usual, we start at 7:30. Can you go to the next slide, please? We have pediatric cancers and COVID today, and none other than Dr. Venkatraman Radhakrishnan from Cancer Institute, Adyar, who will be moderating this session. With him, we have wonderful expert panelists, Dr. Shweta Bansal, pediatric hematologist, oncologist from Mumbai, Dr. Rashmi Dalvi, also pediatric hematologist, oncologist from Mumbai, Dr. Chetan Damne, pediatric oncologist from Tata Hospital, Mumbai, Dr. Manas Kalra from New Delhi, Dr. Pankaj Dwivedi from Nagpur, Dr. Arpita Bhattacharya from Guwahati, right? Or Kolkata?
Sir, Kolkata, sir.
Kolkata. And Dr. Bhaskar Saikia, who's a pediatric intensivist from New Delhi. So over to you, Venkat.
Format in the same touch. So I am not a oncologist, sorry.
I forgot to introduce one more person.
Yeah.
And that is Dr. Neil Nabar, who's an internal medicine specialist from United States. Welcome, Dr. Neil.
Hi, everybody.
Thank you, Purvish, sir, for this opportunity. And I have a very great set of panelists. Some of them are very good friends. Some of them are my teachers and seniors. And this is an important topic which we are going to discuss about. Although I'm going to moderate the panel, but all my panelists have contributed equally. All of them contacted me as soon as they heard that they're part of this panel discussion and gave me excellent suggestions. And some of them will also be sharing their experiences during the course of this talk. I'd request the people who are attending this talk to kindly put their questions on the chat box, and we'll try to take them on. Is my screen visible?
Yes, sir, it's visible, sir.
Okay. Purvish sir has already introduced the panelists. So we have pediatric intensivist as well as pediatric hemato-oncologist in this August panel. And children and COVID have been in recently news. Just 2 days back, we had a virologist saying that the third wave of COVID is going to hit the children in a big way. And Singapore actually believes that the new strain, the Indian strain, the 1.167, is actually going to affect children and has shut down schools. So there is a bit of panic setting in that, the kids who have escaped post-COVID so far are going to be vulnerable to the new wave of COVID. And the first question, we always think that children are miniature adults, but sometimes that's not true. And I'd like to throw it open to my panelists. Do you think COVID is different in children from adults? And if so, why? Maybe Dr. Arpita, you can start and then others can chip in.
Hi, and good evening to everyone. This year's pandemic is throwing last year's conclusions into complete disarray, because we thought last year that children don't get it, and when children get it, it's either MIS-C or nothing at all. But this year, children are getting a lot of other symptoms, which we saw mostly in adults last year. So we are seeing a lot of children with high fever and very prolonged fever. That is something new that we are seeing this year. So the fever is going on well beyond 10 to 14 days. And persistent high temperature, persistent cough, chest X-ray changes. So this is what we are seeing last year, seeing different from last year. Since I do not see adults at all, I will not be able to say, but what I hear from my adult colleagues, and now we have to take COVID ward rounds in turn, so we are doing adult ward rounds as well, is that children are not having so much respiratory compromise than adults. That is our observation at present, but the wave is yet to hit Bengal in the big way that it has hit other states like Delhi and Maharashtra. So I'm not quite sure what we are going to see in the next few weeks. we are quite apprehensive, but keeping our fingers crossed for the best.
Thank you, Dr. Arpita. So far, pediatricians and pediatric oncologists have not yet been worried much about COVID as much as in adults. And there were various theories, and there was this nice review article uh, which showed that probably adults are at more risk because they have more endothelial damage as they grow older, and they're more susceptible for clotting. We know that the coronavirus binds to the AC inhibitor, so adults express more receptors, and they already have a well-functioning immune system which reacts to the coronavirus more severely, and they have more comorbidities and probably lower levels of vitamin D contributes. And they people felt that children are at reduced risk because the immune system is not yet developed. They have underlying pre-existing infections which stops them from getting infected with COVID. The viral load is less. Probably they have a different microbiota. Probably got something to do with higher levels of melatonin and some off-target effects of live vaccines like measles. They're all skeptical, and we do see many patients who do come sick. But the good thing is COVID doesn't kill much in children. The all-cause mortality among children with COVID is about 0.2 to 0.1%, and it has not significantly gone up since the onset of COVID. And a large series of about 7,000 patients, which showed that the deaths were only 0.09%. So that's very minimal. And most of the 20% of children were asymptomatic, and adults, they had fever and cough. And just like adults, patchy lesions and ground glass opacities were common on the CT chest. So I'd like to ask the Dr. Saikya, who's the intensivist here. Do you agree with this findings of this systematic review, that do you get to see, fever and cough as a common presenting symptoms and the CT findings?
Thank you. Thank you. I'm the intensivist in Mexican. So as far as Dr. Arpita said, fever, yes, fever and cough is the most common symptoms. But equally important is the loose stool, pain, abdomen, and vomiting. That is another symptoms. That is, I don't know in the adults, but I'm only looking after the pediatrics. So till now, what we are getting is the vomiting and pain abdomen is also equal features of the fever and the cough. And as far as the CT concerned, we are not doing CT per se in the children's. Most of the times we are doing the X-rays. X-rays is definitely is in the mid right lower lobe infiltration, or in the left lower lobe infiltration is the most common, followed by the right upper lobes. So in immunocompromised children, what we got is same features as per the non-immunocompromised. What I can say, what I have treated till now for the last 2 years. So co-infections, if I say co-infections per se, it's a very rare, I can say. But in less than, if you are saying these children have less respiratory symptoms or CT findings, but if you say more than 10 years and less than 18 years, you will get the adult, I can say the adult people are getting the CT changes or X-ray changes or oxygen requirement that's much more in the 10 to 18 years of age. And in less than 1 year, we are getting actually active cases of the myocarditis. So that's our
Thank you, Dr.
observation.
Saikya. Yeah, we have handled both adult and pediatric patients, and the thing is that pediatric patients tend to present with sometimes weird symptoms, just dullness, and as you said, abdominal and gastrointestinal symptoms are much
Second
more common.
thing is, I like to add here is what I have seen in the MISC, because the children are basically asymptomatic and they're not treating properly, or mild symptoms and they'll leave off. Then after 3 months, they're getting, yes, there is definitely multi-system involvement, maybe because of the hyperinflammatory syndromes. That's what we are observing. Okay.
And as all of us, over the last 1 year, we have all improvised, we have learned. Initially, we were very scared on how to manage. Probably we were overdoing things. Probably now we are underdoing things. So I'd like to know from each of the panelists very briefly as to how they managed patients in their hospital. I'll come to Chetan later because Dr. Chetan is going to make a brief presentation. I'll start off with Dr. Shweta. Dr. Shweta, in your hospital, because there is difference between a corporate hospital and a public hospital. So how are you handling children with COVID? How do you triage, screen? When do you test? What are the policies you're following?
So, Venkat, actually, our hospital is a non-COVID facility. So, what we are doing is that for all the patients before their admission, they have to go through mandatory RT-PCR testing. So one is that there is a testing for the patients, and then there is a regular testing of the staff also. So staff has to undergo for testing for twice a week, like Monday and Friday, they have to go for mandatory testing also. So no, any patient who is having a positive, they are not allowed inside the hospital. Having said that, those patients, pediatric oncology patients who come with RT-PCR positive, then we do have to manage those patients, and we try to triage them. Those patients who are completely asymptomatic, we give them 1 week of gap. So we stop their therapies, we don't give them any treatment, and we follow them for a week. And after a week, we repeat the RT-PCR. If RT-PCR is still positive and the patient is asymptomatic, then in another facility, which is a COVID facility, we give chemotherapy to the patient as per their protocol and whatever treatment they are supposed to get.
Yeah, and are you doing any CT screening?
No,
We are not.
for asymptomatic patients,
Yes,
for patients who are less than 15 years of age, we are not doing any CT screening. We are following them with the counts and the CRP as well. If the CRP is bang normal and the counts are bang normal, they are not decreasing during this time, we are not doing the CT scans.
Dr. Pankaj, what is the SOP you are following at Nagpur?
Yeah, so actually when we begin, this corona begins, we were scared and we don't have any policy, so only by going general terms. But right now we have a policy in place. So every new patient undergo a RT-PCR, and so definitely there is a two group, RT-PCR positive, RT-PCR negative. Only one thing I want to add in all this thing, we also do the antigen test if patient come into the night, because RT-PCR is not working in the night. So one thing is that, and so we do like this only RT-PCR positive patient. If on induction, we have a separate COVID facility in our hospital as well. So we try to admit there and start on a whatever be the clinical scenarios there. We are not doing routinely screening with the CT scan, and we are also not following with the routine serial RT-PCR. We don't wait if clinically symptom is improved. Then we don't even then we don't repeat the RT-PCR for follow-up. So only first time we do the RT-PCR.
Thank you, Dr. Pankaj. Dr. Manas, briefly in Gangaram, what's your policy?
So, at Gangaram, we had been at the center of handling COVID-19 pandemic in Delhi. We had almost around 500, 550 patients admitted at any point of time with COVID infection, children and adults included. So our observation was that the number of kids were really less as compared to the adults, as everybody else would have observed. For our patients, we had the policy of doing COVID RT-PCR testing at every 2 weekly intervals. So all our patients were screened mandatorily. The staff was not tested. The staff was tested only if they had any kind of a symptom. There was no protocol of doing a CT chest screening, too much radiation. And, this whole CT chest thing has just come up in the second wave. In the first wave, the symptoms were much milder and patients were, had much less of respiratory compromise. So we have not used CT chest screening for any of our patients. But yes, 2 weekly screening was mandatory for every patient, pediatric hematology, oncology, bone marrow transplant, immunodeficiency from our unit. And for other units, from pediatric point of view, every child who was being admitted for any illness was screened at the time of admission, or if there were any new symptoms suggestive of SARS, at that time, a testing was done. Now, this year, we also have the CLIA-based testing, antigen testing, which has almost 97% sensitivity. This test also is just as COVID antigen test, but has very high sensitivities available at $800, and the report is ready within 1 hour. So that has come as a big rescue. Waiting times are less, and we are able to manage and handle patients better.
Thank you, Dr. Madhav. So what I would like to highlight is that each hospital needs to develop its own SOP, how it plans to handle COVID patients, because you cannot get one right answer. So the test RT-PCR, when you're going to do, how frequently you're going to do, whether you're going to test the staff or not, it again depends on the resources you have. The consensus is clear that you're not going to do CT chest screening for your children. And what about teleconsultation? Have you, because this is a nice paper from Dr. Bakshi, which showed that, AIMS, they're able to at least, manage 15% of their patients in the outpatient during this COVID period. There are no other publication from India, but are you encouraging teleconsultations open to all panelists?
So Venkat, our teleconsultation work has almost doubled with the onset of pandemic. All the maintenance chemotherapy patients are being exclusively managed on teleconsultations, and they are not coming to the hospital. ITPs and stable patients, hematology patients are all also being managed on teleconsultation. Only patients who are on active chemotherapy, where delaying chemotherapy will alter their outcomes of leukemia, are the ones that have to actually physically come to the hospital.
Anybody else following? Rashmi madam, Dr. Arpita?
Very much similar to what Manas said.
Okay. And it's quite interesting. There are two papers from India, again from Dr. Bakshi and one from Dr. Rachna. They have actually triaged these patients into different groups. Dr. Bakshi has made them into A, B, and C. And A is all patients who have easy access to center. They're treated on ongoing protocol. Patients who have difficult access, their chemotherapy is prolonged. And patients who are unlikely to come were offered oral therapy. Whereas AIMS had much more. They divided into 5 groups based on their severity and how badly they had to be treated. So this can kind of serve as a guideline for other institutions to institute triaging for their own patients. And this was also, that's what TMH did. The TMH, before the lockdown was set up, they also started their teleconsultation, and they were able to achieve a 50% reduction in their outpatient footfalls by using teleconsultation services. This we already. Now coming to persistent RT-PCR, you said, I said Pankaj said they don't test, and I think Manas, you said you test. Have you had persistent RT positivity in your patients?
So, Venkat, do you want me to answer?
Yeah, anybody.
This?
It's open to, because we have faced a few patients who become RT-PCR negative and then after a few days become positive, because we test before every admission.
Yeah. So the policy was, we have evolved with how we have managed COVID in the last 1 year. So initially, the hospital was also demanding a negative COVID PCR, even if the patient had a COVID. And we ended up doing a lot of repeat PCRs for many patients in the first wave. During the first wave, we had 2 patients. One was a child with Burkitt lymphoma with an underlying immunodeficiency, where repeated COVID RT-PCRs were positive. And another one was a child with HLH who had undergone a transplant. For that patient, I think COVID was positive for, almost 8 or 9 repeat RT-PCRs done on a weekly basis. So we did have these 2 challenging cases where COVID negativity was not achieved. Both had difficult diseases, underlying immunodeficiency, a bad HLH who was heavily pretreated. And, there is a case that such heavily immunodeficient patients may be carriers of COVID-19 for a longer time as compared to the other patients, like, a leukemia or a solid tumor patient who is not that heavily immunosuppressed. So, the data is still not there to actually say which patients will be candidates for shedding the virus for a longer time. But there is some, published literature on this where they say that there can be some patients who can be shedding the virus for a very long time.
Absolutely true. Dr. Satya Adav actually published 2 cases and they managed to do an NGS and it was the same virus. So we are still not sure they're infective or not. And again, this is, but generally they say it's the dead virus which is being shed, so you should not be worried. So probably, I guess, we need not test if they are positive after 14 days. And Chetan can also shed some light when he's presenting his cases next. Dr. Rashmi had asked a question on, do you test caregivers? Yes, we do test because the caregivers stay with the patient. What about others? Do you test the caregivers as well?
We are doing a testing of caregivers, especially for the patients who are admitted in IPD. But those patients who are in OPD, we are not testing. I mean, the daycare. For the daycare admissions, we are not testing the caregivers. We are only testing the patient. But for the IPD, we are testing the caregivers.
Thank you, Dr. Shweta. We are also testing our caregivers. So this is the, yes, Dr. Rashmi. Hello.
Yeah, this is Arpita. Hi.
Yes, Dr. Arpita, sorry.
Yeah, can I just share
Please,
what we
please.
do? See, last year, as I said, last year and this year are different things because this year the infection seems to be much more violent. So for a while, we contemplated testing the caregivers every time the child would come in, but it was becoming too much for the hospital to handle because the number of tests that were being done. We are a standalone cancer hospital, and you know that we have limited capacity for testing. So if we were going to test every patient before admission and then the caregiver who would be staying with the patient, then on an average, the daily admissions in our hospital, considering children and adults, would be upward of 30 or sometimes 40 admissions. So that is 40 times to 80 routine tests just to bring them in. And our hospital has a capacity maybe to do about 120 RT-PCRs in a day. So if 80 of them would just be for admission, then it made things logistically extremely difficult. So if the patients we are testing, because you are bringing them in for intensive chemo and you don't want to make them sick if they are positive. So we are testing the child now, but we are not testing the caregiver. Said that, we also have a long stay facility attached to our hospital. Like many other cancer centers, we have the St. Jude India Cancer Care Center attached to our hospital. So the admission policy there is the child is obviously tested when the child first comes in. But there the parents have to be tested negative before they are allowed to stay at St. Jude.
Thank you, Dr. Arpita. So as I said, it also depends on the logistics. Now, I think this is the core of the discussion because we are all pediatric oncologists. We know that the pediatric cancers are aggressive and we are very concerned about delivering chemotherapy on time. I was very worried. I'm very apprehensive about giving chemo. Before we dwell into this question, so should we stop treatment? When is it safe to give chemo? Which patients do we treat? Which patients do we hold? When do we restart chemo after a positive test? And what is the outcome of patients on who are receiving chemotherapy? I just want Dr. Chetan to present his experience at Tata Memorial Hospital on treating patients with COVID with chemotherapy. Dr. Chetan, over to you. Dr. Chetan?
Yeah, I'm here.
Yeah,
Give me 1 second.
Yeah.
You're slide, right?
Yeah, I'm sharing the slides. You can ask me to move them, please.
Yeah. Yeah, so we have also gone through the pandemic for a year, and we see that certain changes are coming up. We are seeing more kids who are coming up positive. But again, I think what happens is most of our kids are staying in the same facility or in Access Life. So we are trying we are trying to contain people as much as possible. If you see here, so far as of 4th May, we had around Am I audible?
Yeah, you're audible, Dr. Chetan.
Oh, okay, yeah. So basically, we have seen around 199 patients as of 4th May and maybe a few more in the last 1 week. So if you see, it is a distribution similar to what we see in the outpatient basis, where most of the patients are hematolymphoid malignancies, and around 30% of them are solid tumors and 5% are neuro-oncology, and that is the distribution of patients that we see. So it is not that a particular group is affected more than the other. So if you see, this is all the diagnosis. So there's no diagnosis that is spared. We have seen solid tumors, leukemias, and neuro CNS tumors equally. So this is a paper that we have analyzed and sent for publication. So we had around 122 patients in the first wave, and most of them were most of them were symptomatic just because of fever. So fever was the only presenting symptom. Only 2% had sore throat, and about 1% had cough, and only 1% who actually presented with breast. So they were tested because they had they were symptomatic. 100 of the 122 were tested because they were just symptomatic. 12 of them were tested because they had a procedure and they turned out to be positive. And procedure was either a surgery or radiation therapy. And 10 of them were positive because they were positive contacts. So most of them remained, 94% of them remained complication free. So only 5 of those 122 developed COVID pneumonia, 1 presented with HLH, and 3 had concurrent cardiac complications. So if you see, as I said in the previous slide, there was 94% of them, 115 did not have any respiratory, did not require any respiratory support. Face mask oxygen was given to 4, and 3 of them were ventilated. So somebody has just asked, what is your denominator? So that is something that we cannot really give you the denominator. We have tested based on symptoms, or if the patient required to be inpatient or in the OT. But we have tested based on symptoms rather than testing everyone. So again, even if we had a denominator of the number of patients we tested, it would still be a false sense of how many were tested. But if you see the overall percentage possibility, we were around 3 to 10% in the first wave. In the second wave, at its peak, around 20% of those tested were coming positive in the hospital. So how we manage these patients? In the beginning, we were trying different things. So we gave antivirals to a few patients, and most of them were sick. So 5 of them received remdesivir. 1 of them received lopinavir-ritonavir combination. Hydroxychloroquine and azithromycin was given to 1 patient. And around 8 patients, we tried to use some sort of immunomodulatory agents, steroids mostly, and only 1 patient we used tocilizumab. So if you see the outcomes, the all-cause mortality was around 7.4%. 2.5% had progressive disease. That is why they succumbed to the COVID-19. Maybe it was just tip over for them. And the COVID-related mortality as such was in 5% of the patients. So 4 of them had COVID pneumonia. They also had associated secondary bacterial infections. HLH was seen in 1 patient. And 1 patient really presented 11 days after being discharged and present with status epilepticus and died within 12 hours after presentation to the ICU. So one question that we were thinking about is how long do these patients remain positive? So we tested these patients every 7 days in the beginning, and that is what is the policy that we try to follow. So after the first positive test, we tested only at day 14, and this we had evolved because we tried to test patients on day 8, then day 10, 12, and 14. That most of the adult patients would become negative by day 14. But our pediatric patients who are on chemotherapy, we saw that around day 14, 83% was still positive, 50% by day 21. 30% was still positive, 33% by day 28, and 20% by day 35. And day 60, 5.1% was still positive. So really was a range. And what we have a gut feeling that mostly the hematolymphoid malignancies are the patients who would remain positive for a prolonged period of time. So when to start chemotherapy is something that everybody faces with that question. So what we did was initially we waited for 14 days, tested them, and then tried to give chemotherapy. And that time we had few patients, so we couldn't experiment with that. Then we felt that they were asymptomatic for 14 days and we were delaying chemotherapy. So we tried to bring that forward. We gave it at day 7. And then when patients were in induction, we continued chemotherapy without interruption. And we had not had any problems with most of our patients so far. Hardly 1 or 2 patients who I will show later had progressive disease, progressive COVID. So our median delay was still 14 days. But as the pandemic had progressed, we were not delaying chemotherapy for most of our patients. And mind you that most of these patients were asymptomatic. Those who were symptomatic came into respiratory infections, definitely we had delayed chemotherapy for those patients. So basically what I feel is that COVID-19 should not be a deterrent for chemotherapy. We continued chemotherapy and now we are continuing chemotherapy without any problems. Only thing is for the DLBCL burkids, we are not giving rituximab because of our previous experience where we feel that rituximab causes a lot of mortality in viral infections. So we continue to monitor these patients with RT-PCR every 7 days, but we do not stop chemotherapy.
Thank you, Dr. Chetan. I think the data which Dr. Chetan has presented has answered a lot of our questions and gives us confidence. So one thing it tells you is that almost 1/3 of your children are going to be positive even at day 30. So it doesn't probably make sense to continuously test them for RT-PCR positivity after probably 14 days. Second thing is that it gives us confidence that yes, patients who are asymptomatic, you can continue to give chemotherapy, no need to delay chemotherapy. Only patients who are sick, unwell, or who generally would not be fit for any chemotherapy if they had, even if they did not have COVID, are the ones you would avoid chemotherapy. The mortality with COVID is very less. The patients who actually die because of COVID usually have advanced disease or under palliative care or have underlying secondary infection. So these are important take-home messages. So now I just open it up to the panelists just quickly in 1 or 2 sentences. I'll go to Dr. Arpita. Do you continue chemo in asymptomatic patients at your center?
If they are on maintenance and they are asymptomatic, we would continue.
Okay. Dr. Pankaj?
Hello?
So it
Can you hear me?
Yeah, I just got your point. I'm sorry, I had to cut. I'm just looking for quick answers.
Yeah, it's if they are on maintenance and they are asymptomatic, we continue treatment. Unfortunately, we do not have a COVID chemotherapy ward, so we are unable to give IV chemotherapy, but we bring them back after 10 days asymptomatic
10 days.
without retesting for daycare and continue with chemo.
So anybody on induction or suppose getting intensive chemotherapy, you tend to wait for 10 days. Dr. Pankaj, what about you?
Yes, so it will little bit same, but in maintenance we hold for 5 to 7 days till we see if there is some progression or not. If he is asymptomatic, we continued his maintenance chemotherapy. During induction, very important time. So we individualize the patient. If they have some other infection or something, the story is different. Asymptomatic, we wait for if he is in between of the induction, we wait count to recover. And as there are some guidelines to use the GCSF, if marrow is in remission, we use that GCSF and again start on a chemotherapy. And if they are a sick one, then definitely we hold the chemotherapy.
Dr. Shweta?
Yeah, Dr. Venkat, I would like to tell, one of our patients, like medulloblastoma, actually, when he got admitted, he was RT-PCR negative. And on day 3, we rechecked the RT-PCR, which is the protocol being followed in the hospital. He became RT-PCR positive. And we were very scared because we have given the intensive chemotherapy to that patient. But fortunately, patients sailed through and nothing happened to it. So these are the things which tell us that those patients are completely asymptomatic and RT-PCR positive. Maybe we can give intensive chemotherapy to these patients also.
Honest?
One question to Dr. Chetan actually. So Dr. Chetan, regarding your data, are you able to predict which patients are going to develop a severe disease and which diseases are going into a severity as compared to others? Is there anything like that so that we can be more cautious for those patients?
So, Shweta, those who really present with breathlessness or low oxygen saturation, high fevers without a focus, those are the patients we try to be more careful. But you see 90% of the patients are presenting just with fever and they are clinically very stable.
So symptomatic or with less symptoms, they remain stable throughout. They don't develop severity.
Yes. So it is very difficult to say. Though because our numbers is very less, as you see, once you have 95% patients who do well, then that identifying that 5% population becomes very difficult. But we have continued. Right now, we have no policy of stopping therapy for anyone.
Do you check through inflammatory markers like CRP or something for these patients?
Yes. So what happens is when the patient presents with febrile neutropenia without a focus, that is a patient we test COVID, and if it is negative, then we treat as usual. But if they are then that patient definitely therapy is interrupted and we treat as febrile neutropenia and wait for him to become COVID negative. If he improves and continues to be COVID positive, we will continue based on his recovery.
Thank you, Dr. Chetan. And there is a meta-analysis recently published by the AIMS group, which says that the mortality in cancer patients due to COVID is just about 5%, and this included about 226 children, and it's comparable to general population. So majority of cancer patients do well, and malignancy per se doesn't seem, at least in children, doesn't seem to increase the risk of death due to COVID. And this is what we also, we have treated almost.
I want to interrupt for
Yes, Manas. Yes, Manas.
The previous slide that you've shown about the AIMS paper, the mortality of 5% is very higher than the general mortality in pediatric patients.
Yes.
Pediatric patients have a mortality rate of less than 1%, but I think cancer patients, children with cancer with COVID, I think there are two or three other studies as well which have shown that the burden of disease, morbidity, mortality in cancer patient with COVID-19 is higher than the general population.
You have a very important point, Manas, because there's a study from the Latin America, from Peru, where they showed a 10% mortality, and I think it's got to do with the supportive care and the resources. Because when we have treated this, we published this is only 15 patients. Now we have treated almost 60 patients with COVID, and we have had only one mortality, and that too a patient who was PS4, very delayed presentation, ALCL, we didn't start treatment. So overall, I guess it also, and the figures from the developed countries are showing that the mortality is comparable to the general population. So I think it just kind of depends on the place and where these patients are being treated.
Venkat, can I add something?
Yes, madam.
Yeah, so this is, some data which is actually on the verge of publication. So there's a global COVID observatory and registry. So based on, in childhood cancers, so based on the data from that of about 1,500 patients from all across the world. So they have, there is a 20%, 43% are asymptomatic, 20% had severe or critical infections. And they reported a death rate of 4%. So which is higher than the rest of the pediatric population. But interestingly, to answer Shweta's question, they did a multivariate analysis of the factors associated with severe patients progressing to severe illness, COVID. And they said that older children, 15 to 18 years of age, children who had cytopenias at the time of becoming COVID positive, those who had just received intensive chemotherapy, and patients from LMICs. These were the ones who were more at risk for developing severe disease. This will get published shortly. But
Thank you, Dr. Rashmi. I think Madam has brought out the salient features. If you are adolescent or a young adult, if you are from a resource challenge setting, if you already have baseline problems like neutropenia, underlying progressive disease, then you're at high risk for mortality. And this is similar to what has been seen in adult studies. You have lung cancer patients tend to have higher mortality than patients who are just getting daycare chemotherapy, adjuvant chemotherapy. Before we jump into management of pediatric cancer patients with COVID, I'd like Manas to share an interesting case with us and how they managed, because this will set us the ball rolling for the intensivists also to get involved to teach us how to treat a COVID patient in our unit. Manas, over to you.
So I think, the case just highlights that, when we say that continue chemotherapy for children with COVID, sometimes things may not go the way we, want them to go. So there can be unique challenges in our country that we'll be facing every day. So this 13-year-old boy who presented with a white cell count of 1.1 lakh, which is, high risk from all categories in our, ALL classification, age more than 10 years, high white cell count, has a B-ALL, started on induction, had a COVID RT-PCR, which was negative at the time of diagnosis, had a severe tumor lysis syndrome. Can you just go back? Went into acute renal failure, had renal calculi, had bad hematuria. Platelets did not recover till, day 20, 25 in his case, and he required lots and lots of platelet transfusions because of symptomatic hematuria. He developed diabetes on day 3 of steroids, and he was managed initially with metformin, and then insulin was added. So a difficult case to manage. Next, please. on BFM4 drug induction. Again, we were hesitant of using too much donomycin. The whole COVID thing was just going up with the second wave, and it was crazy the way patients were pouring in. This child became COVID-19 positive on day 25 of induction. Initially, he was managed at homes because he did not have much of respiratory symptoms, oxygen requirement. He was otherwise stable. His sugars were, well managed, well controlled sugars. Father was a sensible man, could manage the insulin and everything very, very well at home. On day 34, presented with severe weakness, increase in cough, and we did a CT chest. Next, please. And this is the, these are the images. So his CT score was 16 on 25, and he did not, initially have much of respiratory symptoms. But by this time, he had significant cough. He was admitted. Next, please. And he was tachypnic at the time of admission. He was given oxygen. He was given remdesivir. Steroids were continued because, the benefit of steroids in sick patients. But, we have to understand these are children who are already on 4 weeks of steroids for the management of ALL. So they're different from the general population. Clexane was avoided. As I said, he had bad thrombocytopenia. Voriconazole was added prophylactically. Tight sugar control was maintained. Next, please. And, this child did recover. He was hospitalized for 9 days. You can see the second X-ray, which shows that, the X-ray is showing some clearing. Again, somebody's asking about inflammatory markers. Please, the inflammatory markers in pediatric oncology population can be little dubious because we can normally have patients with high ESR, high CRP. These can be normal findings in pediatric oncology leukemia patients. And these were the parameters. And you can see that, by early May, the parameters were kind of settling from the point of view of D-dimer improving, IL-6 improving from 600 to 17, and the LDH was also kind of okay. Ferritin went up to 2800 and then had gone down to 1362. Next, please. So this child, after discharge, because he was okay, his X-ray was fine, he was breathing okay, he did have some cough at the time of discharge. After 2 days of discharge, presented with worsening cough, hemoptysis, and breathlessness. Next, please. And this is what the scan showed. I don't know if the video will play. Maybe Venkat can just tap on the play mark, and you can see the, the pneumothorax that is there in this patient, along with cavities that have developed because of invasive fungal infection. Next slide, please. And you can see these big cavities, the pneumothorax. The X-ray was kind of okay at the time of discharge. But within 48 hours of discharge, this child presented with such a ghastly pneumothorax and invasive fungal infection. Next, please. So we did quite a lot of discussion. It was not suggestive of mucor. He was started on amphotericin B. Voriconazole was again restarted. It was stopped at the time of discharge. So say for 3 days, it wasn't given, and then we had to restart. So this child is in our ICU. We have not put a chest tube because, the underlying diseased lung is there, and the pulmonologist feels it will not really improve his lung, this thing. But, I'm just trying to show that COVID-19 may end, a patient with a difficult disease, and also these disastrous complications. His white cell count is 11,000 now. He's got good neutrophils, but we clearly cannot proceed with treatment in this child with consolidation with such an aggressive fungal infection sitting in his chest. Thank you.
Thank you, Manas. I think this is an important case which Manas has brought here, because it highlights that the challenges of managing a pediatric hematology oncology case with COVID. One is that, these children are already on steroids and you use steroids to treat COVID. And, it's difficult to know whether the child has got a bacterial pneumonia, a fungal pneumonia, febrile neutropenia, sepsis. And then you have further complications, including that, already your acute phase reactants like CRP, ferritin is elevated. Does the child have an underlying secondary hemophagocytosis? So, the differentials are so big, and especially if it's a transplant child, then your differentials even become more bigger. So it's more challenging to manage a COVID positive hemo patient in the ward because you have to cover for so many things. Thanks, Manas, for this wonderful case. So moving on to the treatment, again, as you said, every day we seem to be throwing in the kitchen sink and trying to find out what works and what doesn't work. So we have remdesivir, steroids, anticoagulation, ivermectin, toci, azithro, HCQ goes in and goes out, and convalescent plasma. So we know that plasma doesn't work, HCV doesn't work, HCQ doesn't work, ivermectin doesn't work. I want to ask the panelists, anybody still using ivermectin, HCQ, or plasma in their practice? I guess, yes, please.
Yeah. So ivermectin till now, since last year also, this year also, we are not using ivermectin, doxycycline, and tocilizumab. And here I like to highlight with the chemotherapeutic and getting steroid patients and aortic.
Yes, yes, sir.
So if children are getting steroids are in early stage of the COVID within 7 days, they are likely to develop more complications. And if they are getting actually in appropriate time after 9 days, then they are actually benefited. So it's a very important to using of the steroids in the COVID. So as the in chemotherapeutic patients or immunosuppressed patient, we are using steroids. So these are actually complicating the things. So this is very interesting. When we use steroids, the children are getting more complicated in the ICUs in the post inflammatory phase and getting this early like pneumothorax.
Dr. Sakya, what about patients who are getting steroids as part of their treatment?
So steroid you have to use judiciously in appropriate time. If you have the COVID per se within the 9 days, and you better to use the antiviral first. First you use the antiviral, and if your fever and all other symptoms are not going down or not subsided, then you can use after 48 hours you can use the steroids. So basically children are coming at little bit later stage, not just like adults.
Thank you,
right?
Dr. Sakya.
So people are using steroids early to decrease the fever. That is a very, very dreaded complication for us. But
so the take-home messages: use steroids in the inflammatory phase after the first week. Don't start steroids early.
Yes, that is most important.
These are algorithm which has been designed by the Pediatrics, and I don't want to go through it because people can take a screenshot. The thing is that, what steroid would you prefer, Dr. Sakya? Do you like Dexa or do you like methylpred, and what's the dose and how long do you give?
See, basically both are equally effective till now, whatever we are using, but we are using more methylprednisolone than the dexamethasone.
And what dose do you prefer, methylprednisolone?
1 to methylprednisolone 1 to 2 milligram per kilo.
Okay. And any other panelists, any other steroids preference? Chetan, what do you use in Tata for your patients with moderate to severe COVID?
So we are using dexamethasone, 6 mg a day, and 0.15 milligram for children.
Pankaj, Dr. Shweta, Manas.
One question is there. When the child is already on a steroid, how you decide your
yes, how do you decide? That's even I'm curious. How do you decide somebody is on 60 milligram per meter square of PDN? How do you do?
In that case, we are not using another the steroids. We are continuing that only, but we are giving antiviral early. When this child is coming to the ICUs, basically I am looking after the ICUs only. And so whenever child is sick and coming to the ICUs, then we straight away we are using these things. Then we are seeing also echoes and all those things. If required, we are using IVIG also.
If the child comes to ICU, remdesivir for a COVID positive patient would definitely be given.
Yeah.
Diagnosed.
Manas, do we have pediatric data for remdesivir? Does it really work? Even in adults, it has not shown to improve survival. It's just shown to decrease.
Very true. But at the moment, all sick children who come to ICU, especially underlying diagnosis of cancer, we have been giving. We have planned to give it. We have not used it for many patients, but this wave 2 patients who were admitted, both of them we have used remdesivir at the time of admission.
Anybody has experience with remdesivir, Dr. Sakya and other panelists? I have never used remdesivir in children.
So we are using in only remdesivir also. We are getting good results if we are using early within 9 days. So I have now 1 month old child, 1 month and 10 days old child with a pneumonia, right? COVID positive. So with getting high grade fever, we are not giving any steroids or anything. Just we are giving in the remdesivir, and he is getting better. And by tomorrow, I think we can
This is the Ministry of Health and Family Welfare guidelines, and actually, if you see there for moderate illness, they don't mention steroids or remdesivir. They only for severe illness they
So I
recommend.
think it's too early to say, because the pediatrics per se, people are not seeing only the pediatrics. They are seeing the pediatrics along with the adults, right?
Because
And
the
first
ministry,
is,
pardon, sorry.
that is the Ministry of Health, whatever it may be called. But from our experience, if we are seeing the pediatrics per se from the first wave, we are not using remdesivir much. We are using hardly 3 or 4 patients in 74 patient admitted patients in our hospitals.
So
Now,
should we start steroids for moderate COVID in pediatric patients? Because the government guidelines says no, PGI
No.
says yes. So what's
No.
your recommendation, Dr. Saikia?
So till now, no.
Till now, no. So no
Yeah.
steroids
If
for
it is,
moderate.
if fever persists for more than 9 days, and you are having some signs of inflammation, or you are having some signs of inflammation in the lung, that means some patches in the lung, and having fevers more than 100, then
okay.
definitely you have to add.
Chetan, what's your Tata policy for moderate COVID to start steroids? Or
So unless the oxygen saturation drops below 94, we are not giving steroids to anyone.
Yeah.
That will become moderate. No, once you start dropping your oxygen.
Yes, so then we are giving steroids, and we are not starting remdesivir unless this is day 5 days. It is beyond day 5, day 6 of persistently high fevers. Only then we are giving.
So what I wanted to highlight was that the guidelines are evolving. We still don't have much data on use of remdesivir and steroids. I think over the time, once we start getting more studies, I think each institute is having its own policy on managing patients. So Manas, because you just recently did a journal club, just briefly few words on which patients with COVID you would anticoagulate, because almost every adult gets anticoagulated. So which the child with COVID you will anticoagulate, how long, and what is your preferred anticoagulant, oral or low molecular weight heparin or plain heparin?
So Venkat, we all understand that this whole COVID thing, there is a huge amount of coagulopathy that is going on in the patient, which is the COVID-associated coagulopathy or the thrombotic coagulopathy, which is causing trouble in these patients. The data from adults clearly shows that a lot of patients for whom the studies have been done, the underlying reason for death in many was a diffuse coagulopathy, which led to damage in the lung, which led to damage in the cardiovascular system. So this is an important pathogenetic factor in patients with COVID. Now, when it comes to pediatric, the comorbid conditions are less. The children are more ambulatory. They do not have all the other, paraphernalia carrying with them, which predisposes them to develop thrombosis. But in our patients who have malignancy, patients who have an underlying central venous catheter, and especially children above 12 years with elevated D-dimer and obesity, these are some of the risk factors. Usage of asparaginase, these are some of the risk factors where again the thrombosis risk is going to be high. They have seen the big journal published, the big article published in Blood, where it was found that almost 6% children developed thrombosis. And so there is some gaining interest in pediatric population also for development of thrombosis. So I think every case needs to be individually looked at. We need to identify these risk factors. We need to look at the D-dimer level. If above 5, that is 10 times above the upper limit of normal, and having underlying risk factors, it would be prudent to give this patient Clexane unless the child is severely thrombocytopenic or has a bleeding tendency. So we need to look at, rather than a blanket treatment, every individual patient needs to be looked at. An asymptomatic, very good condition patient who is just COVID positive, even if there is a diagnosis of malignancy, is running around and is otherwise well, no need to use that. But patients with, all the underlying risk factors that I mentioned, and yes, now you're showing MISC, these are the cases which are highly thrombogenic, and a usage of Clexane would be prudent in these patients.
Thank you, Manas, for this wonderful summary of when to use. So once we enter this territory of multi-system inflammatory syndrome, I think these kids need to be under the care of a good pediatric intensive unit and a pediatric intensivist. Dr. Saikia, can you just tell us a few words on MISC and its management?
So basically the MISC we are getting actually post-COVID scenarios. But if we amalgamate it in an acute condition nowadays, also if you see in the less than 1 year, so more than 10 years, you are getting same thing, whether it's called MISC or it's an acute inflammatory condition, it's very difficult to say. So in less than 1 year, you are getting the carditis more. Now I have one child. Now this child developed had symptoms along with the parents on 3rd of April. Parents got COVID positive, but children does not test it. Now this child is treated with a fever, pneumonia, and lots of antibiotics, meropenem, vancomycins, and ofloxacin, metronidazole, azithromycin, all whatever you can say, and including the antimalarial also. But child is having low, high-grade fever continuously going on. So this child discussed with us, and we told them this child is having post-COVID inflammatory syndromes. So what I can see, this child, when they reach to our center, we can see this, there are lots of swelling in the left hand and the left leg. So what we found, there's a lots of multiple thrombosis in the veins. And after giving the methylprednisolone and the heparin infusion, continuous 40 international unit, the child is doing better. All the cultures were negative, right? So today, after 72 hours of giving medications, initial echo was normal. So today I have seen that with echo, there's some amount of pericardial effusion along with some coronary dilatation, Z score of around 2.8. So this kind of scenario we are getting. So if we see in this side also having some amount of transaminitis. So whether it's only because of the hypotension initially or hypoxia initially, we don't know, but there's just some
so sorry to so for the audience, basically MISC is, as you say, is a multi-system disorder where there is involvement of liver, kidney, spleen, and all pulmonary. So each one defines, and it resembles Kawasaki disease, and these patients are prone for coronary aneurysm, and the treatment is basically that in addition to steroids, you might use IVIG or aspirin. So do you give IVIG to all patients who have MISC?
No. Only we have to see the NT-proBNP or TROPI and echo findings. If the cardiac dilatation, the right atrial or right ventricular or right ventricular dilatation is there, then we are using, if coronary dilatation Z score is more than 2.5, then we are using IVIG. Otherwise, we are using the steroid only, and steroid is doing a very good job, but hardly we are using IVIG only in the intensive age
Thank
group.
you, Dr. Sakya. So coming to almost the end of my panel, vaccination.
Venkat, one important.
Yes, Dr. Manas.
Madam has put it in the chat box, and I think it's very important. It's about the oral anticoagulants.
Yes, Manas.
The usage of oral anticoagulants, which is used in the adult population, the apixabans, the rivaroxaban. For pediatric age group, only above 12 years, we are allowed to use that. I don't think we have clear FDA approval for that, but I think there are a lot of studies in adolescents where these drugs have been found to be safe. But less than 12, we are left with Clexane only.
Thank you, man. So quickly to all panelists, will you recommend vaccines for your pediatric oncology patients now? Each one, Dr. Arpita.
Well, the Sahoo is, well, the Pfizer vaccine has just become recommended for children 12 to 15 years.
So Pfizer is there, you would get, but not about your Covishield or Covaxin.
Under 12, there is no recommendation for any vaccine, and there is no recommendation for any other vaccine apart from Pfizer. So we have to figure it out until more evidence emerges.
Basically, the government has not cleared vaccination. Just today, half an hour back, I read that the Covaxin is starting trials for 2 to 18 years. So probably we need to wait for the data for children before we start recommending vaccines.
One more comment, Dr. Venkat.
Yes, Dr. Said.
We have one patient of AML who developed this MISC, and we treated him. And again, after second chemotherapy, he again developed this MISC. So this is a recurrence of MISC.
Okay, that's very interesting. So so it's like recurrent Kawasaki disease. You can have recurrent MISCs as well.
Yes.
And before we end, pediatric cancers are rare, and pediatricians tend to collaborate. Dr. Rashmi Dalvi is the president for SIOP Asia. So, Dr. Rashmi, can you just briefly tell us what is SIOP doing in terms of handling this crisis of COVID in children with cancer, and what else can we do?
Right. Venkat, very early in the pandemic, actually, under the leadership of the SIOP president, Dr. Kathy, and St. Jude Global from there, they started these global collaborative efforts along with some of the most important stakeholders for pediatric oncology across the world. And they first came out with these guidelines for management of common cancers during the pandemic, as well as guidelines for healthcare teams and so on. So this came up as early as 2020 May. And then next they set up a COVID, an online platform, which was like a COVID observatory and a resource center, which basically consisted of a resource library where even now every week new literature is reviewed, and whatever is deemed sensible and good is put up on that site. And then there's also a global registry with more than 50 countries participating, and they have a dynamic dashboard as to the COVID in childhood cancer. There's also an interactive space for collaboration. So so through this platform and through these activities, they have conducted multiple surveys. Many Indian centers also have contributed to this, and they have brought out a lot of data, collaborative data on various aspects of COVID-19, which will be useful. Like one of the things I mentioned about Shweta's question, this also has come from one of these surveys and the registry. Now, there are two things I want to say is that, these organizations coming out with guidelines as well as statement papers is important. One is, they are guidelines, so they are helpful for whoever needs them. But also they are useful for advocating good childhood cancer care at an institutional or a national level, in various places. Also, it is some kind of medical legal support, although 90% of our patients are not going to ever go down that path. But, there was a editorial in Indian Express today that, doctors, please treat patients today and get sued later. So, this kind of gives you some umbrella to work under. So, PHO chapter, SIOP, these.
Thank you, Dr. Rashmi. I think St. Jude Global and SIOP have done a very good service guiding people, pediatric oncologists, how to treat patients and how to collect data, and then based on the data, give recommendations. So about 60 minutes, and we also have guidelines from the Indian the PHO chapter of the Indian Academy of Pediatrics, published in PHOJ, where you can have a look at it. So thank you all. Thank you, panelists. I think we can keep on discussing the whole day. I tried to cover all the important topics, and I can see a lot of questions in the chat box. Organizers, I'm not sure, should we take it up or?
Please take as many questions as you think are appropriate.
Okay, so this is open to all panelists. I'll just going through the chat box now. And the first question was, what about screening patients and caregivers? I think Dr. Rashmi asked us, and again, policy varies. We screen patient and caregivers, and Dr. Arpita said that, it's logistically not possible for them to screen. And then Dr. Purvish has also said that the best policy is for your center and then follow it diligently. There is no correct answer. I agree with it. Yes, Dr. Arpita?
No, I was trying to say that, like you said in the beginning, our policies from last year are different from this year. I was worried about, I was talking about now in this second wave, whether we should be testing. But as Purvish said, each institution will have to, based on their logistics, have their own policy. But it's a bit scary in the second wave here,
And this I put to Dr. Chetan. Dr. Sahoo would ask, would it make sense to perform RT-PCR weekly during induction? What's your take on this, Dr. Chetan?
So it will. So most of our patients we are treating in the COVID ward. So our only indication for doing a weekly PCR is to get them out of the COVID ward. Otherwise, there is no such hurry to really test. We will test the second test would be after 14 days and then weekly.
No, this question I had asked in the context to what the intensivist told, that because in induction we give steroids, and they found that during the viremia, all of us know that steroids might augment the poor prognostic part of the COVID infection. So would it be prudent, because I know the evidence would not be there, does it make common sense to then test these patients so that at the first point we get RT-PCR positive and asymptomatic even ALL, we taper on the steroids or do something on it? That was the point of the comment. Chetan, what do you think?
Yeah, so basically we had 7 patients who were in induction, of which 3 patients we interrupted therapy a little bit for 7 days and then continued. But the other 4 patients, we have continued therapy without any modifications and they have done fine. So again, this is a small cohort of 7 patients, but so far I think we have been lucky or they have done fine.
Dr. Chetan, next 2 questions to you as well. Do you give the chemotherapy in the COVID ward, and or if not, are you having separate areas in daycare and injection room for your COVID positive patients?
Yes, so definitely all the COVID positive patients are in the COVID ward, and they continue to be there for almost 2 months till they become negative and continue chemotherapy there. Those patients who are quarantined, we have a separate facility for them where they come in, get their chemo and go back to the quarantine center.
And there's also a question from Dr. Anand Prakash. Has any of the panelists had a co-infection with CMV, that is both CMV and COVID pneumonia? I haven't had such a situation. Anybody else?
So we are treating also post-liver transplant patient also having COVID. But till now we are not getting it. But previously we used to get before the COVID, we used to get lots of CMV infection. But here it's a very difficult. I don't know. It's because of what is the reason we are not getting the CMV right now for the cultures and all.
Dr. Venkat.
Yes, sir.
This is today's only information. We have one COVID patients whose fever has gone, but again, the resurgence of the fever is there, and everything, febrile neutropenia was ruled out, everything ruled out, and today CMV come positive. Okay. So it's like a.
So you have started ganciclovir
from today, yes, from right now.
It'll be interesting to see whether it helps with COVID. And so the question for rituximab is that in pediatric patients, there is very few places, at least in oncology, where you use rituximab, probably in hematology. And so I would not recommend using rituximab, because data clearly shows that patients who get rituximab tend to do worse and have worse outcomes, at least in adults. What's the other panelists' take on this, on use of rituximab with COVID infection or during the COVID pandemic?
Because we have avoided giving rituximab.
Yeah, we have a paper as well from Tata that, rituximab patients who do worse. Dr. Arpita or Manas, are you using rituximab in your patients during
our
COVID?
Our both 2 Burkitt patients who developed COVID, both came out of COVID without any problem. They were treated with rituximab along with the LMB protocol. But definitely at the time when they developed COVID, rituximab was not given for at least a month.
Thank you.
Same experience over here also with us. We are using rituximab, at least for Burkitt's lymphoma patient, we have not stopped using.
Even we haven't stopped. Fortunately, our experience with rituximab has also been good. We haven't had bad disease, bad problems. The next question is, radiologically, does PCP pneumonia differentiate from COVID? I don't think so, because PCP is very perihilar and COVID tends to be very diffuse ground glassing. So what is the take of the panelist on PCP versus COVID pneumonia, the presentation? And you get a lot of consolidation in COVID, which is very rare in PCP as well.
I think they look different.
Different, yes. But when in doubt, it's better to cover.
And most of the patients are on a PCP prophylaxis. So now the incidence is rare.
Yes,
and if you go into the background, they have a quite long history of steroid they have received as compared to the COVID, which is the acute, really presented in 2 or 3 days actually. So,
and there is somebody who's talking about an interesting paper by Dr. Tracy Hussle. I am not aware of this paper on lymphocyte to neutrophil ratio in the blood Anybody has any idea?
Yeah.
I'm not.
Dr. Venkat, I have actually.
Yes, no, yes, madam.
So this is a very, very interesting paper. I think everyone should go through this paper. I attended their webinar by British Society of Immunology, and they have done on 73 patients, they have done a serious flow cytometry on the patients who were admitted with COVID. And they have found that the patients who had developed a lymphopenia, severe lymphopenia, followed by monocytosis and eosinophils, which were going haywire, they landed into severe disease. And those who were not recovering from lymphopenia, they actually had a bad outcome. So this was a very, very interesting paper.
So this is a prognostic factor, you feel?
This is a prognostic factor, and what they have said is that with the neutrophils also, those who are like neutrophilia, which we see, the inflammatory markers or inflammatory interleukins, which are released by neutrophils, they actually interact with the coagulation parameters in the body, and that's why we have a more coagulopathy in these patients.
So the question is to use or not to use GCSF in a patient with febrile neutropenia and COVID?
So febrile neutropenia and COVID, I think we should not use it. But we are using it as primary prophylaxis, so they should not go into neutropenia.
Suppose, because today I have a patient who's got a just whack for RMS day 6 with a count of 600 with fever of 104. So now after this data, I'm kind of worried using GCS. I was using GCS. What is Dr. Pankaj?
RT-PCR negative and
RT-PCR positive. Patient is COVID, admitted to the ward.
No. So in those patients.
What about others? Manas, Dr. Chetan, Arpita, Dr. Arpita. Would you use GCSF COVID positive febrile neutropenia?
So solid tumors, usually we give GCSF. We have used. I was not aware.
It's okay to give unless the patient has some lung findings. I would go ahead and give.
Would go ahead and give.
But if it is RT-PCR positive, I'll be little more cautious about these patients, and I will not give GCSF until like it is. If I'm thinking that the patient is not going to recover also so soon. So like very close.
One more. Because this is little contrast with how we adult oncologists have felt it, because there is a concern of prophylaxis of GCSF because of the that can increase the cytokine storm. That's what it is. That is felt even the lung cancer. There are issues with that, so people are avoiding in metastatic disease. They are down dosing the therapy doses so that GCSF can be avoided. So what I'm getting from the pediatric group is prophylaxis is okay, which is little bit contrast from what we as adult medical oncologists are feeling. So what is the take-home message? Because the point that is really banging home is, in this COVID era, we should be using less of GCSF.
I think it must be something like, HLH patients. In HLH patients, you don't give GCSF, even if they have too much cytopenia, because HLH is probably worsened by the usage of GCSF. I think the whole thing is being driven.
What paper I'm talking of is a lung cancer patient, is idle lung cancer. So I think this is little bit contrast to what we have been telling in last 8 or 10 meetings. So that is why this point of GCSF is coming in very fast.
I think we need more data.
There is a lot of cytokines which are released with the GCSF also.
Yeah.
Cytokines are coming, and you don't want that cytokine storm to come up. With the
that's why they have recommended not to use GCSF liberally in the COVID.
Yeah, I think it should be individualized. I think we need more data because in our setting we are worried about MDR, we are worried about infections. What about granulocyte transfusions? Can we give? Because again, I've been using granulocyte transfusions for few more patients there in the ICU, although COVID negative, but suppose they're COVID positive. Is it okay to give granulocyte transfusions?
Yeah, I think we can just take a guess, but nobody has the data.
Nobody has the data, yes.
And individual experience is there. We have given a granulocyte to a serious sick patients, and there was no problem as such. And there is no data contradicting to this statement actually, or not in favor as well. So I think it is the
next question is, what is the platelet level where you would defer the use of Clexane? That is beyond which you won't give Clexane. Manas, since you're the thrombosis guy for us, the coagulation.
Less than 50,000 we don't give.
Yeah, that's what we also follow, that less than 50,000 we avoid platelets, oral anticoagulants.
Dr. Amish wanted to ask a question.
Yes, Dr. Amish.
Yeah. Dr. Venkat, just continuing on GCSF, yes, I think all the pediatricians in this panel have said they will use GCSF very sparingly. But the question you asked, 104 fever with PLC of 600, yes, a patient of lymphoma on, say, LMB protocol or a DR epoch, you know that next 5 days patient is going to be neutropenic, patient is in sepsis, how will you not use GCSF? One. Second thing, do we have any strong clinical evidence that मैंने GCSF दिया और cytokine storm हो गया? In the absence of that data, it has to be a case based. We should not, like I personally think, it is very difficult to give a blanket statement that use GCSF very sparingly. Because you need to save life in neutropenic sepsis. And we all know that neutrophils are required for the recovery from sepsis. So I'm a little confused, as Tarini said, and we need a clear-cut answers from all the panelists.
What I meant was what we discussed, that prophylactic GCS is what we are trying to avoid. And in the adult one, we concluded that way. But in a patient who's sick, like as you told, we would use GCS. That's what we concluded the adult one. So here it is actually the contrast what we are concluding. So that's why.
Correct. I agree, Tarini, and some clarity, because I would use GCSF in a neutropenic sepsis patient.
Amish,
so I agree.
If the patient is RT-PCR positive with COVID positive patient,
still we are talking of only those patients only.
I think it should be individualized. I think, we need more data.
I would like to avoid GCSF in those patients who are RT-PCR positive, even if they are neutropenic. Because if you see whatever the data with the GCSF, is available in the normal patients also, you see that it decreases the neutropenia by 2 or 3 days, and there is not overall decrease in the mortality by using the GCSF. So we will, by considering that data and by considering that whatever we have in information, I would like to avoid GCSF in these patients, because we know that there is a good chance of having a cytokinemia with this patient by using a GCSF secondary to the viremia plus whatever the disease the patient is having. So I will avoid.
I completely agree with you. Is it our theoretical fear of cytokine storm, or is it been proven? See, one thing is to give GCSF prophylactically when TLC is 5,000 in a COVID positive patient. Another is when the TLC is 600 or 500 or 400, and you know that these patients have received combination chemotherapy and likelihood of recovery is 5 to 7 days as compared to 2 to 3 days with GCSF. Do we have any data where TLC of 600 give GCSF cytokine storm in COVID patients?
We don't have that data. We don't have that data. I think we have to wait for more data, and I think each physician can decide on his own. Next.
Can I put in a word?
Badira, yes, nice to see you, Badira.
Yeah, hi. So the thing about when we are talking about positive patients with RT-PCR, and first of all, for such patient, you won't be giving a myelosuppressive chemo in the first 2 weeks. But if you are talking about anybody who has an FN, who has received a myelosuppressive chemo, then suddenly on day 5 or 6 have become RT-PCR positive, for that patient, if it's a chemo which had warranted primary prophylaxis for GCSF, I think you can proceed with it. But for such a patient, it would be better to give GCSF rather than a peggrafil, where you can titrate your granulocyte. The whole thing, I think, in a setting of such a patient, what we are worried about is neutrophils flooding in the lungs for a patient who is going to have a pneumonia. So in the first week, definitely we are not expecting that also. So it would be prudent. It's something we have to balance and could be given in the first week. So that shouldn't be an issue. If an asymptomatic child, definitely you can proceed forward.
I think this is an interesting topic for a meeting by itself, whether to give GCSF or not in COVID patients. Moving on, I have to take this question because my wife is asking this question. So she wants to know whether do you give radiation therapy for COVID positive patients. Dr. Chetan gave data that it's safe to give, chemo in patients who are asymptomatic COVID positive. Her concern is that every time they put in a COVID positive patient in the machine has to be sterilized. So it's logistically different. And I can't see any data anywhere about stopping radiation or giving radiation in patients who are COVID positive. Anybody has experience?
So, patients.
Yes, Chetan?
Yeah, so we have, because the machine area gets contaminated, we have avoided and delayed radiation to bridge the gap. We have given chemotherapy for these patients.
Okay, so most of the centers are avoiding radiation, and it's more of logistics.
Absolute sense to avoid for 10 days and avoid radiation, the whole drama of sterilizing the whole unit.
Yes,
just give some gentle chemo and wait.
Yes, thank you, Manas. And yeah, vaccination for caregivers. I think I encourage all my caregivers to get vaccinated if they're eligible, because it's safe. It's not a live vaccine. The kids are not going to develop COVID because. So there is no doubt about it. Please encourage all your caregivers to get vaccinated. And
Venki, there was one question
yes, sir.
about ALL. Patient is for induction and RT-PCR positive for COVID. Would you use PEG as positive?
So we generally used elastogenase, that is the native elastogenase, because the cost of the PEG. But I don't see any because elastogenase is an important drug, and I don't see any contraindication for using PEG-LAS. Yes, probably if you are at high risk for thrombosis, like Manas said, you have comorbidities, you're obese. Probably in those patients, you might delay till they become negative. But if you're treating with a curative intent, I would proceed. What do other panelists feel?
Or you may add Clexane for the patients who are not very cytopenic, but continue with the intended chemotherapy for ALL.
Any other panelists, any other opinion?
So prophylactic Clexane is actually a difficult call because ALL induction, definitely the platelet is going to be low. So most of the time the platelet is low. So using a Clexane is a query. Yes, PEG asparagine is a good choice because then the frequency of hospital admission will be reduced. So that may be the cause we can use this PEG asparagine. But there is no contraindication. As you go to the SIOP guidelines, they also recommend to give the either PEG asparagine or asparagine in an induction patients.
Yeah. It would not be very prudent, wise to use prophylactic Clexane unless there's a thrombophilic patient or had this thing.
So very clear, we don't use it, but I'm saying that in case you have a patient where, you are really thinking that there may be a thrombosis, a very obese child who is 14, 15-year-old, whose platelets are okay, in those situations, you may consider it because that is a high risk situation of COVID positive with undergoing chemotherapy, may have a central line, maybe getting a PEG asparaginase. But again, most of our patients are thrombocytopenic and you'll not be able to give them. The question will come if you are in reinduction. Reinduction patients, when you start the reinduction, at that time your platelets are normal. You are giving them a PEG asparaginase dose, a big dose. You are going to give them dexamethasone. And if you turn COVID positive in that scenario, there is a high chance of thrombosis and you may consider adding Clexane when they are not thrombocytopenic.
Thank you, Man. I think we have run out of questions.
Venkat, just a small hint. I may sound, Dr. Sahoo here. I may sound foolish to all the pediatricians. So if I, as my understanding of it, if I delay, let's say in the reinduction phase, the PEG for maybe 10 or 12 days post RT-PCR positive of COVID, would it be any harmful to the patient in the outcome?
I don't think so, sir. It won't.
So does it not make sense to delay it by 2 weeks?
I agree. I don't think so. Delaying your PEG will make any change.
Because elastogenase, many times we always make up later on if the patient is too much sick in the first.
I agree. We in routine clinical practice we do it many times.
Yeah.
Perfect. Thank you, Venki.
Yes, sir. Just before I close, I would like to thank all my panelists and the organizers and Purvish, sir. And first of all, getting all the pediatric oncologists. We are a small rare breed, and I was seeing so many COVID. Semi-webinars, and I was wondering, if we can get a chance, and I think Purvish sir read my mind, and it's so nice to give a voice to the pediatric oncologist here and had a great discussion. And we are going to see more cases, pediatric and the number of cases are going to rise, and such discussions help practicing oncologists in a great way. Thank you, sir, for this opportunity.
Thank you very much, everybody, and just reminding you that in 2 days' time on Thursday, we will have our next meeting at 7:30 p.m. Dr. Ullas Batra will continue the discussions on moderate and severe COVID patients, particularly oxygen, ventilation, and steroid. And it will be followed by Amish talking about anticoagulation and Clexane and everything, and D-dimers and all. So once more, thank you very much. Stay safe,